Hello, my name is Stephen Rowe. I'm from the Johns Hopkins University School of Medicine, and I'd like to thank you for the opportunity to speak today on the emerging role of PSMA imaging. I'd like to thank Dr. Stern and the other organizers for putting together this virtual meeting. I do have a couple of relevant disclosures for my talk today. Prostate-specific membrane antigen is a transmembrane carboxypeptidase that's highly expressed on prostate cancer cells. And indeed, expression has been identified on more than 95% of prostate cancer tumors. There does seem to be some correlation between expression levels and tumor aggressiveness. And for all of these reasons, PSMA is an excellent target for molecular imaging of prostate cancer. There's a large extracellular domain of PSMA that has been leveraged for binding of both small molecules and antibody-based radiotracers and therapeutic agents. And we know a fair number of things about PSMA PET at this point. We know that it has a moderate sensitivity and very high specificity for preoperative nodal staging, has a high detection efficiency for sites of biochemical recurrence, and it's effective for guiding focal therapy for oligometastases and selecting patients for endaradiotherapy. Let's talk about each of those indications briefly. In regards to preoperative staging of high-risk patients, at the meta-analytic level, single-center studies with gallium PSMA have found about a 60% sensitivity and essentially a perfect specificity for preoperative nodal staging at the patient level. Our own experience with an F18 labeled radiotracer has found similar results. Most patients look like the one on the left, where there's clinically localized disease and no evidence of disease outside of the prostate. A rare patient, such as the one on the right, will actually have unsuspected systemic disease, and perhaps 20% of patients will have identifiable nodal involvement in this high-risk prostate cancer population. In our study, the sensitivity was about 70%, and specificity approached 90% at the patient level, and similar in terms of the packet level, with the packets being defined as the left side of the pelvis or right side of the pelvis, and the fat pad over the bladder. In regards to biochemical recurrence, with gallium PSMA, the sensitivity numbers are honestly a bit all over the place. But one thing that tends to hold true is that at higher PSA levels, there's a higher detection efficiency. That shouldn't be surprising. A higher PSA level would imply a higher volume of disease and hence would be easier to detect on the scan. We looked at a small group of patients that had biochemical recurrence, a very low median PSA of 0.4, and all of these patients had to have negative conventional imaging in order to qualify for this study. I believe the results of the study are the true additive value of a PSMA scan over conventional imaging. And out of the 31 patients that we imaged, we were able to identify a putative site of disease in about 2/3 of them. As with gallium PSMA, at higher PSA levels, the detection efficiency of the scan increases, and the number of patients that have more than one site of disease increases. Here's a couple of examples of what these images in biochemical recurrence patients look like. Here is a patient that had a small local recurrence in the prostatectomy bed. You can see here the uptake behind the bladder and amongst prostatectomy clips, subsequently confirmed on dynamic contrast enhanced MRI in the lower right. And then the most common finding in patients with biochemical recurrence is one or a small number of lymph nodes in the pelvis. Here you can see a small lymph node in the pelvis, far too small to call on conventional imaging as being pathologic, but with abnormal PSMA uptake. If we move on to patients that have a little bit higher volume disease, so say oligometastatic patients, we find that some patients do have definable small numbers of sites of disease, such as this patient with a single presacral or perirectal lymph node. This patient had a PSA of 3.9 at the time of the scan, received SBRT, no systemic therapy, and PSA became undetectable and stayed undetectable for a long period of time after this second scan. There's a patient at the other end of the spectrum. This patient was thought to potentially be oligometastatic with a single suspicious lesion on bone scan. Everything else on bone scan was felt to be degenerative or traumatic, and CT was normal except for a small amount of sclerosis at this site in the rib. However, the PSMA scan showed hundreds of lesions throughout the bone. Most of these lesions were small, Marrow-Based, infiltrative. They weren't causing any sclerosis with the associated bone and hence weren't visible on bone scan and weren't visible on CT scan. The patient did have a PSA over 100, so the PSMA scan does in fact concord with the biochemical picture of this patient better than the bone scan did. And here's a patient somewhere in the middle. So it does have a limited amount of disease, some lymph nodes in the pelvis and retroperitoneum. However, after receiving SBRT to those sites, the PSA continued to climb. The patient came back with what appeared to be disseminated bone metastases, a little bit more subtle on the scan than some other lesions, but nonetheless definitively positive. And some patients that are treated along this paradigm do fail in this way, where they have disseminated metastases upon rescan. If we move out one more step on the spectrum to patients with more widespread metastatic disease, we can consider treating them with PSMA inhibitors bearing lutetium-177, which is a beta-emitting radionuclide. And if we look at the efficacy of this in patients with metastatic castration-resistant prostate cancer, about 40% of patients will have an objective response to this therapy with a PSA drop of 50% or more. In terms of any PSA drop, the percentage is about 70%. And this comes at the cost of relatively tolerable toxicities. Some low-grade nephropathy occurs, some low-grade xerostomia occurs, but these are generally self-limited. And we now have 2 large prospective multicenter trials that have borne out those results, the meta-analytic level, the VISION trial, and the therapy trial. And we can expect TCM PSMA therapy will become FDA approved and should become a part of the standard of care for many patients with widespread metastatic disease. What we don't know yet about PSMA imaging is a number of things. Here's a selection of those things. We don't really understand necessarily how prognostic findings on scans are in different patient populations. There are some real questions about how to follow response to therapy, given that a decreasing androgen signaling leads to increased PSMA expression. So treating men with androgen-targeted agents may drive PSMA expression and appear to make their scan look like they're having progression, even if they're responding to therapy. And we don't know yet what role artificial intelligence is going to play and what we're doing in the future with PSMA scans. We do have a couple of hints about prognostic value of the scans. So in patients that are lymph node positive on the scan and lymph node positive in histology, versus patients that are negative on the scan but positive on histology when they undergo a radical prostatectomy with an extended pelvic lymph node dissection. Patients that had a negative scan, a false negative scan, actually have longer biochemical recurrence-free survivals. So there's prognostic value even in a negative scan and even in a falsely negative scan. We also know from the Oriole trial, in a post-hoc analysis that was carried out after the conclusion of the study, that for patients who have all of their lesions that are visible on PSMA scan treated versus those who only have a subset of their PSMA positive lesions treated, the patients that have all their positive lesions treated have better progression-free survival and better distance metastasis-free survival. When we think about following response to therapy, we of course want to be able to follow response to ADT or second-generation anti-androgens. However, initial experience with PSMA response to ADT that was done by Tom Hope's group out at UCSF showed that if you imaged a patient right before starting ADT and then a couple of weeks after ADT, the lesions that were present on the baseline scan became more apparent with higher uptake, and a number of new lesions were identified. However, the story became more complicated than this, and this isn't necessarily typical of all patients that are starting on these kinds of agents. Let me tell you a little bit about a 2-center single-arm study of patients, a total of 18 men who were imaged with VCF-PYL PET right before and then 2 to 4 months after starting Abiraterone or Enzalutamide, and then they were followed for a total of 48 months. In this case, findings on the scan, some lesions became hotter and more apparent, others became colder and less apparent, and there was a smattering of different patterns how overall tumor burden appeared to change from the baseline scan to the follow-up scan. We came up with a couple of metrics to try to define this on the whole patient level. And we tracked out different patterns of changes between the 2 scans, correlated that to percent change in PSA. There was a type of change of a sort of mixed response, but predominantly increased disease that did seem to portend an immediate rise in PSA, whereas a number of other patterns showed up in patients that generally had decreases in PSA. Perhaps more importantly, these whole body tumor change metrics that we utilize showed that patients that were overall having increases in the amount of PSMA-avid disease or apparent PSMA-avid disease did have a shorter time to therapy change than those patients that had this obvious increases in the amount of disease that was apparent on the scan. And even more importantly, the same trend held true for overall survival. Looking at baseline metrics only was not associated with either time to therapy change or overall survival. Let me touch just briefly on artificial intelligence. I think in the near term, we can expect AI to provide lesion classification, whole body tumor burden assessments, and information on prognostication and decision making. Already, machine learning algorithms are pretty good at identifying hotspots and not missing sites of disease. I think there's probably still some specificity issues that need to be addressed. But overall, as far as sensitivity goes, these algorithms are learning quite quite quickly how to identify sites of potential disease on the scan. Of course, there does need to be some level of nuance in terms of classifying lesions, and that's some of the work that we're focused on, is how to pick out the things that may be PSMA expressing other cancers or are benign lesions that happen to have PSMA expression. So I think there are already multiple indications for diagnostic PSMA-based imaging that have been extensively explored. We're just starting to understand PSMA-targeted PET findings as imaging biomarkers. And honestly, there are more questions than answers so far for the interface of PSMA PET with AI. I'd like to thank many of my collaborators, and again, thank the organizers for the opportunity to speak today. Thank you.